Thanks, Terry. I know that we want to make full use of the afternoon time, so I am going to just quickly introduce the session and the presenters and moderator, and then I'll hand it off to Anne. So the focus of this session is very much on collaboration across settings as well as innovations within settings. To begin with, we have Dr. Anne Colbourne, who is a Director of General Internal Medicine at the University of Alberta Hospital. She also plays multiple provincial roles, which you will see in her bio. She's Medical Director leading a transformation in care processes, and she also has a very strong clinical passion in the area of disease prevention and health promotion in the area of diabetes. She seems to straddle Newfoundland and Alberta like a true Canadian, and that, of course, also brings a richness to her understanding. Dr. Dante Morra is Medical Director at the Centre for Innovation and Complex Care at the University of Toronto, which pioneers new models of care with the goal of healthcare transformation. He is a leader in hospital process transformation improvement. Dr. Nigel Murray is the President and CEO of Fraser Health Authority. He's responsible at the system level, and which includes acute care, community-based, residential services, home care, mental health, and public health. So very much of a regional systems perspective. Shirlee Sharkey is President and CEO of St. Elizabeth Healthcare Organization, which is a leading national healthcare organization known for its social innovation and pioneering practices. The moderator for this session is Dr. Kaveh Shojania. Dr. Shojania is Director of the Centre for Patient Safety at the University of Toronto, where he also sees patients as a general internist. Dr. Shojania is also the Editor-in-Chief of the British Medical Journal Quality and Safety. Thank you, and over to you, Anne.
So I'm here today just very grateful for the opportunity to share with you an initiative that we've been leading in Alberta called Care Transformation. And this is fundamentally grounded in the belief that we need to stand back and ask ourselves the question is, what is it we're trying to accomplish in care, and how do we need to do it, given the resource base that we have in Canada? So we believe that there's a significant care agenda. We believe that it has to be patient and family focused, in not paying lip service to it, but really trying to understand what that means. That there are wonderful human resources available to us, but perhaps they're not deployed as well as they could be. And that truly, at the end of the day, it's about engaging hearts and minds in transforming the care agenda. So that's what we've done. This piece of work that we led last year, we're now in phase 2 to try to replicate what we did last year, was really grounded in the general internal medicine community at the University of Alberta Hospital. And it was based on a visioning document called Repositioning General Internal Medicine that I created and our team created within 6 months of my arrival. And what struck me at the time was that general internal medicine in that particular community had a sense of having lost its way, wasn't quite sure where it was supposed to be and what its core values were. So we did a visioning process that led to the repositioning report, and out of that report emanated this schematic, or as our framework, meta framework, and meta stands for mobilizing energy, taking action. And it really was around engaging all the people who needed to be engaged to move this care community forward. So at the heart of it, what you see is patient and family focus with a collaborative enterprise around that. And we're not pre-stating who the collaborators are, because I think it's probably broader than health professionals, and we need to start thinking broader out into other kinds of sectors. We're respecting in this framework that there's a continuum of health, from wellness to acute and episodic illness, hopefully, that chronic disease is in there as well. And also there's a spectrum in terms of the healthcare delivery system. First and foremost, the people we serve see themselves as individuals, not as patients. First and foremost, people have stories to tell, and when they get up in the morning, they don't think, I'm a sick person in need of care. What they think is, I want to enjoy this day, and how can I enjoy it well with the conditions that I'm managing? So it's about respecting that agenda and trying to figure out what kind of collaborations we needed to make to help promote better health for all. So we recognized that we had to ground this piece of work somewhere and that we couldn't boil the ocean. So it was our intent to really start in the acute care environment, but I hope as we walk through the next few pieces of information that you might reflect on whether this model might work equally well in a community-based setting or in a home-based setting. Because truly, we framed up this piece of work under the agenda of delivering on an integrated plan of care. And ladies and gentlemen, I would say to you today that to deliver on an integrated plan of care, we have to respect that the person in front of us has their own set of issues that they would like us to address. They have values and preferences that they would like to infuse into that care agenda, and if we're not respecting that, then we haven't arrived. So we grounded this piece of work in the acute care setting. In phase 2, we're testing the boundaries of that. More significantly, we're reaching out intentionally to the primary care community as well as into the continuing care community, and really trying to bridge that continuum in a much more meaningful fashion. So, patient story and how we're going to deliver on that. So we framed it up under the Integrated Plan of Care banner. I would submit to you that the Integrated Plan of Care really could be looked at from 3 perspectives and possibly others. First and foremost, it's the Integrated Plan of Care from the perspective of the person who's receiving the care. And what does that look like? And what do we need to do at a systems level and certainly within a jurisdictional level to actually deliver on that well? So if you think about the individual we've heard a lot today about an individual living and trying to manage a chronic condition. We've talked a lot about the health sector accountability framework for that, but we haven't talked at all about what contribution other kinds of sectors actually have in relationship to delivering well on that agenda. So I think we need to think about what other kinds of partnerships need to be respective and what kind of policies, procedures, governance, stakeholders need to be represented. From a systems perspective, we created this framework, which really is an attempt to illustrate that I believe there are 10 domains of health systems that need to converge on the integrative plan of care. And if we look at any one of those, whether it's policy, a governance system that respects frontline leadership, decision supports at the interface of care, respecting roles and scopes of practice, and really trying to maximally deploy and optimize the utilization of our very precious health human resources, we need to have much more intentional conversations about how all of those domains of health systems converge on the integrated plan of care. If we do not ask ourselves the question whether every decision we make or whether every intervention we make makes a difference truly at the interface of care, we have not arrived. How do we do that well? So this is not for you to read. My assumption is that these slides will be available to you, but this is really the highest level overview of this 28 deliverable initiative that we did in 8 months on time under budget. And the money that was used to fund this initiative really was fundamentally to support backfill so that we could free up frontline providers to actually attend transformation teams to actually develop the change that was required. We fundamentally looked at the packets of work in terms of frontline leadership development, reconfiguring the environment so that it was actually more conducive to care. We looked at reframing our documentation sets so that instead of having teams documenting in silos, that we actually not force people, but we changed the documentation process to actually bring team members together to document in the same place. We looked at bringing accreditation standards and care maps and pathways into those processes. We used benchmarking for expected length of stay to do some real-time education around what expectations were for this particular individual who was in our care today. And we looked specifically at transitions of care, and that's going to be a much bigger piece of work. We divided those big buckets of work, as I said, into 28 deliverables, which we delivered through the working groups, which are in sort of in the lime green section of this. And I would invite you, if you're so inclined, to download this presentation and have a look at that at your leisure. Phase 2 is more complex. We originally did our work in 70 beds in general internal medicine. Right now we're tackling 580 beds through all of medicine in 2 major facilities in Edmonton. So fundamentally this was about engaging the hearts and minds of the people who show up to work every day to deliver care. We believe that if you ask the people that you've employed in your organizations what needs to be changed to do a better job today, they will tell you. And they'll also have some really good ideas about what could change to actually make it better. Furthermore, if we actually ask the people that we're there to serve how that worked for them, if we do not do that, then we have missed another huge opportunity. So as part of our engagement strategy and as part of phase 1, we reached out to the patient and family engagement group within Alberta Health Services, and we said, how do we do this? And we invited stakeholders, patient and family representation into each of our working groups, and so we ensured that we had patient and family voice with us every step of the way to hold us accountable to that agenda, because we know how easy it is when we are in huddles talking to health professionals or to other administrators. It's very easy to slip into it's all about us and how our day is going to work, but fundamentally, if we want to stay true to the agenda, we need to have those voices present in a meaningful fashion. So I think that was a really helpful thing for us, and we have broader engagement going forward. And my challenge to each of the frontline team members really is, on every day, for every given individual that you're serving, use that as an opportunity for engagement, use that as an opportunity for feedback, and use that as an opportunity to understand how what we're doing today could be improved tomorrow. We had a Frontline Leadership Council, which became the overall clinical design team for our initiative, and this frontline clinical team basically vetted all the clinical redesign, came through this council, and nothing was signed off, nothing was implemented without the Meta-Council approval. And again, we now have a patient and family representative as a permanent member of our Frontline Leadership Council. This council, I would add, had representation not just from the health professionals, but from the unit clerk, and I would anticipate in the future we would have people like environmental services and so on also present at the table with us. So our burning platform was dispersion. Dark green is good, red is bad. Red is in emergency, light green is anywhere in general internal medicine, but not on the right unit. Blue is off service. We were massively dispersed. Our patients were all over the hospital on up to 13 different units. You can imagine a physician team rounding on 13 different units. That's pretty inefficient. You need to pack a lunch to go on rounds, basically, to survive it. What we did through this iterative process, as you can see, is we drove towards a process where we have a unidirectional flow process that patients now are assigned according to where the bed is, and we now have home units, and this has really had a significant impact on team functioning and in terms of flow and access. We mapped out the team process in terms of who on the team is doing what, and this is going to be the basis in phase 2 of some fundamental process redesign for particular areas where we see opportunity for improvement. As I mentioned, we revamped our documentation processes, and we developed interprofessional learning opportunities. So instead of having siloed learning opportunities where we had physicians attending physician rounds and nurses attending nursing rounds, we created interprofessional rounds on a weekly basis, and that's been really quite interesting because people now know the difference between a charge nurse and a unit clerk. Like, seriously. But anyway, it was really quite interesting because there was a lot of, I didn't know you did that. So it's really been quite valuable in terms of understanding what each other does and creating very different kinds of conversations. So we went forward with the premise, right bed first time. We partitioned off the care appropriately. Prior to this initiative, it's interesting that in Edmonton at the University of Alberta Hospital, there was no intermediate care kind of space for patients in a general internal medicine community, and those patients would have been held in emergency because they were not sick enough for critical care, but they were too sick for the wards. So we partitioned off the care into a 4-bed intermediate care unit, and that's actually decanted those patients from emergency. We opened a 16-bed transitional unit, which is functionally more like a subacute, so we did not fill that transitional unit with patients awaiting long-term care because that would have ceased to be helpful probably within a week, but we kept the long-term care, waiting long-term care patients on our acute care wards, but we moved the patients who needed subacute kinds of services off into that unit, and that unit has now proven to be the highest throughput unit in the whole Edmonton zone compared with like units, and as a result of this partitioning off of care, 25% more patients now go home compared with previously from the general internal medicine community. The notion of rapid rounds, the name we stole from St. Joseph's in Hamilton, but it was really built on the premise of the daily touch point and the rapid rounds. Bullet rounds, some people call them, but I have trouble using the word bullets and associated with patients. I just really so we've got to find a different name, and so we did the lit search and stole the name rapid from St. Joseph's, so thank you. But basically, this happens on a daily basis, 7 days a week, and our goal this year is to get to twice a day. So beginning of the day to set the agenda for the day, what needs to be done today and who needs to do it, and then to do the touch point at change of shift and sign out rounds at the end of the day to reaffirm the care agenda. So this is what happened. On the left-hand side of the screen, what you see is the 3 general internal medicine units prior to this initiative and the number of hours that the patients spent in emergency on stretchers waiting to arrive on the ward. And prior to this initiative, we had patients who spent 3+ days down there. In fact, some people spent their whole hospital stay on stretchers in emergency because we just couldn't get them into the acute care environment. The Tier 1 measures, I'm sure, are not new to any of you, but we really are driving to the 4-hour target and the 8-hour target for admitted patients. But we actually reduced the emergency inpatient length of stay by 80% through this flow processing cohorting. So that's been really positive because we think it gets our patients much more rapidly into the space that they need to be in. Our volume has gone up significantly, so same bed base, basically, but our volume has gone up by about 130%. So this just represents the same way. And we've leveled the inflow-outflow a bit more. I didn't show historic data, but basically we still have, what's interesting to me in this is even though there's less outflow on the weekends, there's actually less inflow on the weekends as well. From a benchmarking perspective, we're running below CHI for all of our top 10 admitting diagnoses. And what you'll see is that when our initiative started, you see a bit of static. As you get about 2/3 of the way through the slide there, you see a significant drop in length of stay compared with CHI. And we've knocked almost a day off our length of stay. What I don't have, and I wish I had to show you today, is what our readmission rates look like. I'm still waiting to see those, and I'm a little bit fearful, I have to say. Overall, what you'll see is the length of stay, as I say, we knocked almost another day off those. But what you'll also see in the blue is that our expected length of stay actually went up, and that may have been because of the concurrent coding and real-time documentation. This was a massive intervention, 28 deliverables. I've given you a 12-minute snapshot of something that could take a whole day. So I'd welcome your questions or reach out to me via cyberspace once I return to Edmonton. Thanks very much.
Well, I think we'll do this like the previous session, which is that if anyone has any very specific technical questions, we can maybe take one now. But otherwise, I'll turn over to Dante Morra, and then we will have a large Q&A session at the end.
Okay, well, I'm very excited to talk about my 2 favorite topics, one being revolutions and the other being general internal medicine. So before I get started, I just want a couple of disclosures, as every good speaker should. I sit on the board of directors of PCAS, the makers of the Pharma Trust Delivery System. The CICC has received funds from Sanofi Aventis and Boehringer Ingelheim. I've done lean and regional integration consulting with Deloitte and received funds from RBC for a career book. So in this box is a technology that is so dramatic, it's going to completely revolutionize community care and internal medicine. And I'm going to open this box in about 10 minutes, and I think it's going to be sort of really important as to how all this is going to come together. But I took the topic very seriously. I was asked to talk about revolution, so I wanted to say, are we set for a revolution? So to define revolution, the first one is a revolution is a dramatic and wide-reaching change in the way something works or is organized. That's the definition. So the second is a Danteism, as I put this in there, is that revolutions occur when significant change does not happen through natural evolution. I believe as social beings, we actually avoid revolution because it's bloody, it causes lots of problems, there's lots of disruption that happens with it. So we generally don't want revolution. So Andre Picard won't like this slide, but hopefully it'll all come together at the end, is I actually believe within healthcare, we're this little boat. It doesn't matter where you are within primary care or hospital care within a region or deputy minister of a health area. We are this boat going towards this giant wave coming towards us. So we've talked a lot about what this giant wave is. So there's unrelenting demand, whether it's chronic disease, intensification of therapy, and aging population. It's busy. There's unrelenting demand coming towards us that everybody feels that. We have a supply problem. We are set up for episodic care. Everything is designed for episodic care. Fee-for-service, the way that we organize ourselves is for appendicitis, not for COPD, chronic renal failure, and social isolation. But the thing that's missing is this. There's lots of industries that have this. The thing that's missing is this, is actually, and it's something that Camille said, is that the problem is we could have avoided that wave a long time ago if we evolved and we changed directions. The system is designed to not change. And all the different providers or groups looking for their piece of the pie have created system inertia that is so structured together that the problem is an inability to be able to change. That's the system problem. And when we make system change, all we do is do subsystem, and we take garbage from my office and I throw it into someone else's office. And it's the lack of the system, it's that inertia that's the critical issue. And it's this. This is a diagram from a paper we published in the Journal of Operational Research that looked at all the operational factors that drive GIM in complex medical patients. And this is just a simple part of it, looking at the emerge, surgery, and medicine, looking at all the intricacies. And the reality is that it is really, really complicated. And that complexity pushes us away and stops us from being able to move. And that is the perfect storm. It is not the demand, the redesign. It's the fact that we're having trouble with that piece. So before I get to the box, I want to give you 3 case studies in revolutions. And hopefully it'll come together. The first is operational improvement. And this is a critical one. We are, within healthcare, a cottage industry operationally. People decide, one hospital says, we're going to do hips and knees. We're going to be a cardiac center. We just hired a pulmonary hypertension specialist. Let's create a clinic around it. And the reality of it is that we have very little understanding of the flow of patients that come from ambulatory into hospitals and all the intricacies of that. And that creates a major, major problem because Staney said all the frontline providers want to do a good job, and that is true. But the incentives are incredibly powerful. If you pay someone 3 times the amount to read a test than to take care of a complicated patient, they will. And so what we found in our work, so UHN is the canary in the coal mine, University Health Network. We're about 50% volume funded. What we find is that when we get volume funded, we act just like everybody else. We take the money up front and we discharge the liabilities, and there's externalities everywhere. And if you start to move towards volume funding, whoever's this more sophisticated person, and it's usually the operator, they win. So as you're starting to do this, you have to be, it's a very important point that was made, is the payer and the operators have to work together to get this right. If you're going to change the models, they have to work together and they have to go slow and find places to do it. It's sort of like an iceberg, if you can see it. It's a diagram. The little blue line is the water. When people look down at operational problems and they say, who are all these complicated patients? How are they flowing through the community? What they see is the tip of the iceberg. It's all the other subparts in the bottom that are critical to understand. If you understand the operations of this, so just the last presentation, if you understand the operations of how these patients flow through, you can process redesign around them, but it is boring, grinding work that takes years, that changes the way that people operate. It's not sexy in any way, and it takes a long period of time. But it does work, and you can dramatically redesign care along continuums without new net resources in, and we published around it, and these models have been used, and they're very similar to what was just shown. But your organizations have to have the intelligence to be able to do that. And right now, most organizations don't know what's driving their populations. So the first disruptive bit is really good operational management within organization and understanding the flow between the community and within your organizations. The second is data. So what we use data for is we report it up. We're starting to get hospital report cards. We report patient satisfaction up. What we're not doing is pushing that data down. And this is a critical point that's been brought up multiple times, is you cannot solve these complicated patients with a physician, a nurse, a pharmacist, or even just primary care. You need everybody. And so you have to create a unit of a team, and then you have to push data down to that team in a scorecard. And we're doing a lot of work in this area. And the example of this is Toyota, knowing what their defect rate internationally is meaningless. But if they know in Cambridge, on line number 3, the defect rate is high, and they have that unit and they push that down, you can have dramatic change. And so patient satisfaction is a good example. We've surveyed our frontline providers, like 1% of them look at patient satisfaction in the organizations. And also, the way that we do this is we send surveys 6 months later after someone leaves the hospital, and we ask them 60 questions, and we get a 5% response rate. And then we take that data back to a nursing unit, and 6 months later, and we say, oh, by the way, this is our data. How are we going to do about this? This doesn't work. What we've done is we ask every patient who leaves, we identify the groups of teams of nurses and doctors and pharmacists, and we give that data to them that week. By the way, this is your patient satisfaction that week. This is your hand washing rate that week. And by the way, that team over there is doing a little bit better. Why don't you go talk to them? It's incredible what happens. We take our hand washing from 60% up to 100% in like 1 or 2 cycles. The data has to be good. The dashboards have to be there. The team has to be identified. And so as you're looking across communities and groups, the team has to be there, and then the data can come down. And this is highly disruptive, revolutionary work that can happen. But you have to identify the team. The data has to be good. It has to be real time. The third piece, and you've heard this around communication. So as you start to manage these complicated patients that have chronic renal failure, COPD, heart failure, atrial fibrillation, socially isolated, and they're bouncing around, they are incredibly complicated. And so you get teams, they're basically a project. They're a project, and the patient can be part of that project. And it's the ability to have information going around those patients that is the critical enabling tool to change the way that their care goes forth. And this is what we do is we might as well use these string things with the little cups. Because our technology is pagers in hospitals, and the reality is the clinical communication, urgency, context, having triage of messages. When I have a patient and sign over, the patient interacting with that. What we're looking at within EMRs is buckets of data, PACS, labs, clinical documentation. That is overwhelming in these populations. What you need is that clinical communication layer and how you bounce back and forth between the different providers and ask for help at the appropriate time. That communication layer is a really, really important piece. And we've been working on this for about 7 years, and we've been jumping up and down, waving our hands. It's finally catching right now. So some of the larger funders are starting to understand that actually that communication synthesis layer is incredibly important. And it starts with looking at 15% of the time pages go to the wrong people. Starting to use new technology, following people around. That communication layer is essential if you're going to transform the care of complex patients across the community. And I'm happy to say, actually, we've worked with a vendor, QRS, to create a clinical messaging solution that allows patients to interact and our teams to be able to work in urgency. And it's just been we're a finalist for the Edison Award in New York, so we'll see what happens in April. So I think there's lots of opportunity in this area, and I believe this is a revolution. So I promised to tell you what was in this box. And what you just simply need to do is, what people want is this, right? People are so desperate for this technology because your foundations can raise money for it. People actually want you to have a CT scan or an MRI in your computer, in your community. And people can relate to this. And what we've been taught to do is to believe that an individual intervention, a technology, a pill, or some sort of shiny object is going to transform the way we do it. But the reality is that is just this. It's a nicer boat. And the boat still flips over. That's the reality is that, this is the critical thing is the box is empty. And this work around complex patients, that 2%, that cost curve, it is bent by understanding the operations and how they flow through. It is bent by having data going to the teams that can take care of them and identifying the right teams. And anyone who stands up and says one group can do it, they can't. And it is bent by having the communication structures so that those teams can be successful as those patients translate across the system. That is how and it's really hard work, and you have to change people's activities. So I believe, getting back to that concept of the inertia, this is us. We're standing there, and the water's coming towards us, and we could have just turned the boat around early, but we all really don't want to change because it's too risky for us. The providers that make a lot of money reading tests, they have something to lose. You across your organizations, you know what services you should consolidate, but do you really want to have that battle off with that other group of stakeholders? And so as the water's coming towards us, there's this sort of this stasis of not sure how to be able to move forward. And I think the reality is that most of these interventions are actually quite light. Once you get the teams right with a virtual ward and other interventions, once you get the teams right, they're actually quite light. They're technology light, but you have to go in the right direction. And I think you can start slow, and that's effectively what we do in the center. Is we create the space and an environment where we can actually work on that rigidity problem and introduce new innovations. So thanks very much.
Thank you very much, and good afternoon, everyone. It's a pleasure to be here with all of you to take part in what I have found so far has been a very stimulating and wonderful discussion. When you think about the intellect, experience, and brain power in this room, we should be able to solve all of these problems by the end of today's session. Well, let's hope anyway. Let me say thank you to CHSRF for hosting the discussion and in this stimulating environment and inviting me to take part. So thank you for that. My name is Nigel Murray. I'm the President and Chief Executive Officer of Fraser Health Authority. And based on this morning's excellent debate, I'm going to change my topic. Sorry about that, CHSRF, but I think I'll go to this one. And I'm going to retitle it called, my new topic is Hospital CEOs are the Tyrannosaurus Rex of today's healthcare leadership. Uh-oh. T-Rex doomed to extinction. I think we heard we've got to evolve or become irrelevant to the modern healthcare system. And I'm not just talking about those with the title of hospital CEO, though they could be quite a big target for the future. I'm also talking about those of us with the veneer of providing a program of improving the health needs of our population. But really deep down inside, we're still so hospital, inpatient, and specialty focused. Though that's very important, it's not going to resolve the issues we're debating today. Kind of hospital CEOs in drag, dressed up like we want to manage the continuum of care, public health drivers, and the continuum of community-based services. But really, as we've just heard so many speakers say, we're often the slaves to the custom and practice of our hospital-based traditions and power bases. So I was going to change topics, but I'm going to go back there because I can see some of the CHSRF minders getting anxious. So back to my presentation. So Fraser Health, as you can see there, we're a population of 1.5 million, actually soon to become 1.6 million, and we have 20 municipalities. Fraser Health is the fastest growing health authority in British Columbia and one of the fastest in the country. It is geographically large and culturally diverse, and we serve that huge population. The challenges over the next decade of our population will grow and age faster than any other region in our province. And on average, the past 5 years, every year we have grown by approximately 2.5%. And alarmingly, our emergency departments are growing upwards of 7 to 8%, and we have 12 emergency departments in Fraser Health Authority. Our growth in geography and demographics create significant challenges. Our acute sites commonly are at occupancies well above 100%, which creates its own inefficiencies, and we struggle to provide the best quality of care for our inpatients, often in most inappropriate environments, corridors, hallways, lounges. You've all experienced this before. And while our acute sites continue to operate over capacity, we know many of our patients currently in our acute hospitals would be, as we've talked about so many times this morning, much better served in the community. Building our community resources is absolutely essential to moving forward. And as a chief executive, we as leaders must nurture relationships with community providers and agencies and patients, residents and clients. And we must have that concerted effort to invest in innovation, high quality care, and really an innovation that can completely change the way we work. As Fraser Health Authority, our relationship with our communities is so important. I might just skip forward one slide. I was just talking about that one before. So moving on to our relationships with our communities, in particular our physicians, is extremely important. Our urban areas like Surrey and in its surrounding communities have one of the lowest GP to population ratios in urban Canada. As you can see from the slides behind me, Fraser Health has the lowest population rates for our GPs in anywhere in British Columbia. Therefore, it is essential we partner with our physicians effectively. Today, I want to speak about the work we've undertaken to integrate physicians into our service planning, as well as some of the other healthy community partnerships that we have developed. So the big shift that we're talking about. Well, I came from New Zealand recently, 4 years ago, from that system. We have a significant challenges as we do here. In New Zealand, we seem to have been a little bit more advanced in our relationships with primary care, but it is difficult and continues. In Fraser Health, the relationship between community physicians and health authorities, I can only speak for mine, is underdeveloped. You know, I have to criticize myself here publicly. We have been asleep at the wheel in many areas of our relationship with primary care, and I don't just mean GPs and family doctors, but other providers. While building on relationships is difficult, I assure you that there are jurisdictions that are looking towards being successful. It is my hope in a few short years, Fraser Health will be one of those jurisdictions. As I alluded to, we know the challenges of the future will not be solved in the acute care hospitals, or as I mentioned in my slight deviation, hospital CEOs. Community management of chronic disease, robust home support services, and community-based rehabilitation must be at the center of our future healthcare system. To drive the big shift that is required, new partnerships are required at all levels. A shift from the silos we often talk about to integration, standardization, and where appropriate, consolidation. All three of those words have appeared in our discussions today. And from clinical independence, no health professional, no administration, no hospital, no any program can operate totally independent. So if we are to be successful in engineering this big shift, so we avoid that tidal wave we saw before, what would success look like? We would explicitly acknowledge the importance of relationships at all levels, trust between providers, administrators, and government, that's sometimes very fraught in the political environment, would be enhanced, and solutions would be generally generated in a collective fashion, but with determination. Healthcare is not provided by individuals. Again, a theme from today. It is provided by teams with strong leadership and determination. Too often, physicians are left or allowed to be left to act as individual islands and sovereign providers. We must create platforms for engagement and foundations of a model of shared accountability with incentives that align with that. Strengthening partnerships between team members will bring focus to the needs of patients and communities we serve. To better understand community needs, we must partner with our community leaders, be they municipal government leaders, or non-governmental agencies, or other organizations which provide leadership in our communities, sometimes quite informally. Fraser Health's Healthier Community Partnership Initiative is a partnership between Fraser Health and its 20 municipalities. Along with our municipal partners, we have developed community action plans for each of our communities we serve. The action plans are an opportunity to move the focus of health from treatment and remediation to promotion and prevention through concrete action. Municipalities are encouraged to consider healthy living strategies when developing bylaws, their official community charters, and to conduct social marketing and education campaigns. Fraser Health has dedicated a portion of the organization's community health specialists time to bring best practice, expertise, and knowledge to assist our community partners in developing their community action plans in partnership with ourselves. Often I go to our communities and they say to me as a chief executive, you've got $2.7 billion in your budget. What can you do for us? And we always say, well, you know, we can do a few things, we can do some things, we can do a lot of things, but we can do a whole heap more, tons more, if we do it in partnership, collectively, and engage the communities we serve. While making progress at community level, work is also being done at the individual provider or physician level. As I mentioned before, our relationship with community physicians is utmost importance to Fraser Health. I said we have the lowest ratio of GPs in family practice in urban Canada in many of our areas. And I said previously, we've kind of been asleep at the wheel. Working in collaboration with the Ministry of Health and the BC Medical Association, Fraser Health and other provincial authorities have developed a common governance framework essentially for building mutually beneficial partnerships with common incentives. Through the formation of General Practice Services Committee, a joint initiative between the BC Medical Association and the Ministry of Health, funding has been allocated to shared goals and vision, collaborative services committees, which include the health authorities like my one. Representatives from those stakeholders provide additional alignment and guidance. Through these well-defined processes and structures, new partnerships have been required that support us to be successful in this important endeavor. Physician relationships. At the center of our new physician partnership are divisions of family practice. Divisions are groups of family physicians who voluntarily organize, incentivized by financial incentives, but also qualitative incentives such as improving patient care. Divisions partner with the Ministry of Health and the regional health authorities to address primary care needs in their community. We see divisions as the key vehicle for partnership moving forward. Work to date has largely shown success in reconnecting health authorities with the community practitioners. As noted, we have not done a good enough job in that connection with community physicians, and divisions offer a platform to do so. Divisions also offer a forum for shared accountability and a shared decision-making process. We must work to develop this capacity. We've seen the relationship between the Ministry of Health and the divisions become the primary venue for collaborations. Health authorities must ensure the avenues for tripartite decision-making, resource allocation, and shared accountability remain open and productive. So what about the action? We've seen early successes that foreshadow the potential of robust partnerships with family physicians, partnerships based on trust and shared accountability. In Fraser Health, our home health case managers have embedded in family practices to support general practice in accessing necessary home health services and to provide high-quality care for complex patients. As you heard, we are very congested in Fraser Health. So the ability to discharge and keep those patients flowing as we try to accommodate our huge population growth is very important to us. So in acute care, the House Doctor program attempts to integrate community physicians into the hospital and provide enhanced on-site coverage. Additional supports were provided to general practitioners based primarily in the community so they can take on the role of the most responsible physician in the hospitals rather than be just trapped in their practice. Initial outcome data shows the average length of stay for patients tied to this program decreased by 16%, or just in that study period up to 20 acute beds. Physician engagement with the hospital has improved. The multidisciplinary input to care planning teams is now part of the norm. As we move forward developing our partnerships with our physician community, the integration required to meet the needs of patients will not be achieved without investment in shared information technology, and we've heard so much about that too. At Fraser Health, we have invested heavily to align the authority on the same IT platform across our entire 12 hospitals and many areas of our community-based services. Our My Health system allows GPs and allied health professionals to access the information they need to provide care while offering patients the ability to review their own case care plans online. Through My Health Plan component, electronic care templates are available to families, physicians, patients, and allied health. Our initial pilot in the White Rock community, south of Surrey and Vancouver, has seen 572 patients develop shared care plans with community physicians and allied health. So in conclusion, I would just highlight the Fraser Health model as shown here about the interconnectivity of all the aspects we spoke about today. And clearly, the reform agenda available to us, again, with the intellect and experience in this room, we should be able to really make some progress, especially if we have the courage with that leadership. Thank you very much.
Good afternoon, everyone. It's also a pleasure to be here. I hope I can leave you with one message, how divergent thinking and coming up with creative solutions is probably more critical than anything as we try to revolutionize the system. So bear with me for one moment. You know, when you're a panelist, you do have your mind wander sometimes. Also, when you're in the audience, your mind wanders. Here's a creative thought as we listen to so many things. Who had the best socks and shoes so far to date? Robert, you were my winner where you had the Argyle socks on. Did anyone else notice his socks? You're on the road to a revolution. But I hope that in this brief presentation I can talk about changes in behavior and attitudes that started to change for certainly individuals and families with a mental health crisis, and also changes in behavior and attitudes for the health professionals dealing with this population. A little bit about St. Eliz, because we're not a CEO of a hospital, I guess because I'm not dressed in drag, I'm standing here naked. Because we really do bring a lot of the messaging from the home and community care environment, which is all about people and the lives they live. But we are very committed to partnering with the various agencies in the healthcare system so that we can see change happen in a meaningful way. And I think that change is about bridging our thinking, bridging our processes and programs, and our structures. And it's a challenging undertaking that I think we sometimes simplify by saying, well, we're going to put this here, we're going to change this. And actually, Roger Martin was speaking at one session that I was listening to, the Dean of the Rotman School of Management in Toronto, and he was saying successful businesses. Now, he was talking about design thinking, but now listen to this. Balancing the analytical mastery and the intuitive originality in a dynamic interplay is going to be the success for the future. And you know what an interesting way, and how an interesting way to put what we're trying to do sometimes when we talk about change and transformation. So let me talk about my little example of mental health, but I think it is a big learnings and lessons that we can bring from this initiative. And I'll spend less time about the detail of the program and more about what we have learned from this initiative. This was a partnership with a community teaching hospital in North Toronto, North York General Hospital, and team members from St. Elizabeth. And what we did was put in place our crisis program that was funded for a whole different reason in the community and put those expert clinicians into the emergency department at North York. So immediately, a solution was created. Didn't have to hire new people, didn't have to position things differently, but built on the capacity that existed in the system. It's piloted in 2007, evaluated in 2008, and then in 2010, 2011, direct funding from the LHIN took place to continue this initiative. Now, obviously, with the diversion program and the goals, some of the problems were the visits were much longer with this population of people, about 42% longer, and they keep increasing over the years, probably about 2.5% increase every year with people in crisis going to emergencies. And also the physicians at North York were saying many times they had to admit them because they did not know or were not aware of community agencies and didn't feel safe. So obviously the objectives, as you can see, was really about diversion, about awareness of community services and better outcome for this population. Just from a flow, what's important from this flow is that you can see that we situated, in essence, crisis and community knowledge into an environment, but then additionally, when in fact the crisis worker worked with the emerge discharge clients or the other areas, they referred them to community agencies and also to the St. Eliz crisis program that you recall was already funded for another reason. So we kind of bookended both of these processes to try to have consistency and try to change the culture actually within both groups. Now, the actual program and the list isn't, I think, what is as relevant as there was time put in place for the crisis worker to work directly with the individual and the family to come up with what their plan was, to deal with the crisis of the day and to also come up with an alternative plan. And I think that freedom and unleashing the capability of the crisis worker was one of the key lessons to learn. They had 8 weeks that they could provide services to people who were diverted from the emerge visit. They could have 1 visit a day. They could have 8 visits a day. Minimum, most individuals on average, the minimal amount was about 5 visits during those during the 8-week period. But the key issue was they were empowered to customize this and to work directly with the individual and the family. They were not with the same pace and rush that was occurring in the emergency. The evaluation framework, you can see. A couple of highlights, it was interesting in this setting, which has a lot of seniors, the average individual in emerge requiring these types of mental health interventions were actually females, range from 43 to 57, with the diagnosis of a depressive episode. And I'll explain a little bit why that was the population that was being referred. The program results and highlights what was really critical and what the funders were very keenly interested in is that the reduction rate in revisits to the emergency room from this population of people reduced 57%. So they looked 28 days after they had been discharged from the emergency room, what was the reduction in revisits to emerge, and there was a 57% reduction, which is what everyone was keen about, but there was certainly many other things that we were learning about community awareness and understanding. Some of the key implications more than anything was an incredible education campaign for everyone, for the community, for the people in the emergency. Probably the crisis workers had a good understanding, but very few others really understood what other resources actually were already funded, existed, and the competency was there. Also, a lot of the programs did have different admission and eligibility requirements, and it was important to have that information understood by the people in the emergency room so they could hand that off effectively. More implications. What was very clear was our thinking that this had to be bigger than simply an ER diversion, and we really needed to look at best practice for an overall integrated mental health approach for this population of people. Also, what was key was ensuring that we emphasized a profound client-centered approach. It didn't really matter who was there and how much training they had if they were not focused, really participating with the family directly, there would not be the results that we were looking for. Key success factors that I have pulled out was a 24/7 access, critical. There was no point having the crisis worker there unless they were there at the critical times. Another interesting, and this came from the direct individuals and family, access to peer support. That's what they wanted more than anything. Not the physician, not the nurse, but peer support. And also, we prioritized some of the programs so that we were able to move them into short-term case management rather than be on the wait list for the people coming into the emerge. And this was another lesson for us to know that you had to prioritize what were some of the key programs rather than put them at the bottom of the list and then wait again. So the formula for optimal care, this is, I think, just to show that the emergency room is clearly only one piece of, I wouldn't even call it a revolution, one piece of a small change to begin to change behaviors and attitudes. There really needs to be a synergistic combination between healthy lifestyle, the primary caregiver, the just-in-time virtual care, access to home care, community care, things like pre-scheduled visits where people aren't waiting for hours, changes within communities and neighborhoods that have a whole different approach to this population. So you can see our whole world thought it was about emergency and diversion. When you sit back and look for the good socks and shoes, you see that there's a whole other place you should be looking at. Lastly, I think the good news is that we felt that the program was very good and we had accomplished some of the outcomes and the targets. But as you can see, the target keeps moving. And I think that we need to go well beyond diverting funds, diverting resources, but divert our thinking as well. And I think we need to plan by embracing the interconnected elements in healthcare, yes, and the ones that converge on, and rather than ignore them, the ones that converge on the evolution of our society. And we need to understand both of those are constant forces changing if we really want to have the revolution. Thank you.
Thanks very much. I'm a frequent speaker, but I'm not often a moderator of a panel, and I was sort of recalling sitting in grand rounds often and watching the head of the department apparently not paying attention, but then able to ask a very insightful question at the end. And I have to admit, I was starting to struggle. Gosh, what the heck am I going to ask? Because these are kind of different projects. And I'll admit, I'm going somewhere optimistic with this, but I'll admit at first I was thinking, gosh, these don't sound like very revolutionary to me, and they seem kind of small projects. And then I thought, well, I often, when I do a lot of my day job involves often helping people who are trying to improve quality, do it a little bit more rigorously and evaluate it and so on. And I often remind them that, you know what, there's trillions of dollars spent on basic science research, and they produce like a 1% gain in something, and that's like headlines sometimes, 1% reduction in breast cancer mortality or something like that. But often in quality improvement, we expect we're just going to come and enthusiastically hit it out of the ballpark. Like there's going to be a 50% reduction in something. We're going to eliminate errors, eliminate defects. I mean, most of the times if someone claims that they've succeeded that much, there's something wrong with the project and the reporting. So, maybe baby steps is actually what we need to do. And maybe a revolution, maybe the problem might be actually a little bit in the name of the session. If we're trying to get people to work together, we have to get them used to working together. We have to have everyone maybe in their local environment have the experience of a successful project. That sometimes reaching down from 30,000 feet and saying we're going to lay waste to the way you've done things before, that may not be the best way to change things. It may be people talk about cultural change, they need to change, but sometimes culture changes by a series of very concrete steps where it becomes part of what they're used to. And if they don't have any personal experience with these types of projects, then they probably won't accomplish anything. And the changing people's attitudes over time usually takes time. A very famous physicist by the name of Max Planck once said, "Scientists don't change their minds, they just die." And there's some truth to that. It's the rare person who changes what they've believed all along. And so sometimes these baby steps are the way to proceed. And so I think maybe that is really the theme for the panel today. I don't mean by baby steps to suggest that any of these are inconsequential projects, but I'm saying compared to the morning where we were talking about, do we need accountable care organizations? Do we need to radically change the incentive system and so on? Maybe we need those, but maybe we also need just more and more examples in people's own backyards of whether it's something like the virtual ward, which is being funded and evaluated, or whether it's this primary care network, or the diversion in the ER, or any of the examples that our four speakers spoke about, where you need to roll up your sleeves, understand the complexity of what you're dealing with, and try to fix it, and people will be engaged in that work and hopefully go on to the next one. So I don't think I have a burning question to ask, but I thought I would just try to set the context a bit, because at first it was a little bit bewildering to me in terms of what are we supposed to take away from these four different speakers, but I think they are all trying very local, like they say, change begins locally. I think they've all tried to collaborate across silos to improve some very specific, often operational problem, and also the quality of the care they deliver. So with that, I think I'll open it up for questions from the audience. I want to emphasize, by the way, that people should feel absolutely comfortable to ask a question in French. We do have all these headsets, and I don't think there has been as many questions from our Francophone attendees as there could be. And right here, there's a person putting his hand up. Use the microphone, please.
So this one's in English.
Okay.
Sorry to disappoint. Rick Gibson. I'll frame this by saying that I'm a community-based family physician practicing in Nova Scotia. And thank Nigel for the fact that he mentioned the community and discussed how to bring about a revolution in community care, because up until that point I was a little stunned to find out that inpatient beds were to do with ambulatory or community care. I didn't realize there was beds in the community. It was interesting, so I was trying to generalize, and I guess what I learned out of this was if we're going to try to do anything in the community, I guess we better frame our burning platform as inpatient bed overcrowding and emergency department overcrowding. Because, the fact that we've got this kind of 19th century model of care in the community doesn't seem to be recognized as a burning platform. What you've got is solo practitioners. So, hearing that we should identify the team that's going to work on the quality improvement project is sort of interesting, because my team consists of me and the nurse that I pay off my fee-for-service income, and the rest of the team is kind of invisible to me. Sharing the data so that we can drive a quality improvement project's interesting, except for the fact that the Nova Scotia EMR is great for individual patient care, but doesn't have anything in it that would allow me to look at rolled up data on my patient population. And on an inpatient unit, I would get length of stay data and information about my diseases I'm looking after, et cetera. But in the community, I've got nothing, and the government doesn't give me anything, and the district doesn't give me anything, so I got nothing about the patients I'm looking after or how I compare to other doctors. And you were talking at length about the communication infrastructure there, about how hospital staff can talk to each other. And, our version of a new communication strategy is some division of the Department of Medicine sending me the new paper version of their referral form that I'm supposed to fill out by hand, despite the fact that I'm working off an EMR. So, my point is more of a comment than anything else is, it's a conference about innovation in ambulatory and community care, and, it's and the other aspect of this is you got to count the number of speakers that are hospital-based secondary or tertiary care specialists or hospital CEOs. So Nigel was right when he said we're a little over-focused on the hospital system, and we got a long way to go to realize that there's a need for innovation in the community. Anybody wants to respond to that? It wasn't really a question.
No, that's a very fair. We were aware of that. And I think. Go ahead. Actually, Shirley looks like she wants to say.
The only thing I would respond to is I think it's a bit limited when we look at what's happening in the community to suggest that that is just primary health care. And there is a whole array of innovative 21st century leading edge community activity that takes place. It's not as big, it's hard to get on the radar, and a lot of it is very client-centered because it has to be, because you're either in the communities or you're in people's homes. So possibly, only focusing on the physician piece of that community component is important, but that shouldn't shape how we look at changes and opportunities and strengths, because there's many other areas, and mental health is one field in the community, and also we've seen it in health promotion and in healthy baby care, etc., some incredibly innovative approaches that have not touched the acute care space. And I think that's where we need to bridge. It's not that it's all on one end and all on the other, but I think if we can get some incredible bridging, then we can see some very interesting innovation. And what's even more important, it really will be anchored with the starting point being the client-centered approach and wishes.
Follow up on the comment again. I know first of all, I'm very aware that many of us are hospital based. I would say that I do worry often about innovations in ambulatory care being difficult when so many people are in solo practice, and I don't say that to disparage solo practitioners, but it's like in the hospital we have virtual teams often, in the sense that it's just whoever the PT is that day and whoever the doc is and whoever the nurse is. It's not at all the model that we often get in NASCAR, aviation, of people who really work together. But in a solo practitioner, it's even worse to say. And then, you're obviously at least interested, you're here. But then there's other solo practitioners who probably are quite happy just doing what they've always done, seeing patients and letting, if the disaster happens, they get admitted, and eventually they'll find out about it. But right now, it does seem like we're going to have a problem with engaging any significant innovations without figuring out a way what to do with solo practitioners or small groups. And I don't know if either the panel members or people in the audience have thoughts on that. Looks like somebody over here.
Thank you. Yes. My name is Cal Gutkin. I'm the CEO and Executive Director of the College of Family Physicians of Canada. And I think that your comments at the moment, as well as many of the comments from the panel this afternoon and this morning, are very relevant. That was probably a very good lead-in to my maybe making a comment at this point in time. I agree with Shirley with the statement that was just made. There has been some outstanding innovative work and progress being done within the communities outside of the formal institutions in the hospitals. I think all of our organizations have actually been working very intently for probably most of the last decade to try and address the kinds of things that are being addressed here today. And we're far from there yet. This is a journey, and we have a destination that is still a fair bit down the road. But the role of family physicians, without a doubt, is just one. We're one player, and that's very clear from the comments made today and at most sessions like this, and we recognize that. We hope to believe that everyone sees family physicians as important players in the healthcare system at the primary and, for that matter, secondary care, and in many communities, tertiary care part of delivery of care. But we're one player, and one of the things that has changed quite dramatically, certainly in my time, which is now about 15 years as CEO of our organization, is the receptivity on the part of significant numbers of family physicians across the country to change the way they are practicing. And in many cases, it is very difficult for them to do this. In many cases, they go to work every day and are just trying to respond to the deluge of patients they have to see. We've gone through a time with a shortage of family physicians. We greatly value the concepts around team-based care and the expanding scopes of practices of other health professionals to work with family physicians as part of teams. We are now across the country seeing some outstanding examples of this, but they ain't there yet. And they're not there yet because the whole system hasn't embraced it, because primary care, family practice as part of it, has not really been seen as being important enough to support in the way it should be supported. Whether it's in the delivery of care aspect in practices, whether it's at the level of research, continuing quality improvement, teaching and education, it's supported, but it's secondary. The whole primary care sector is. I think meetings like this have to elevate that to the level of priority in the minds of everyone who is here representing whatever jurisdiction you do. So we do have, and we came out this year after 3 years of work with our vision for the future of family practice in Canada, the patient's medical home. This is a patient-centered model. We worked on it with patients, with our other health professional peers. It still needs lots of work. We have government support in various provinces, federally. We want to work with all of you to make this happen. It's all about team-based care that is truly patient-centered. It's a new model for primary care, for family practice, that we can all do together, and it addresses almost everything that was talked about here today. So we welcome you to join us in this initiative to achieve what I think we're all trying to achieve for the people of this country.
Very much. Right in the
Rachel Barr, the CEO at the Canadian Nurse Association, and I guess after hearing all of the presentation and certainly this afternoon, I think that if we really want to bring some revolution or transformation, I think we need to start not from the hospital trying to reach the community. I think we need to start with people, citizens living in a community, and we need to strive as professionals or as organization to help keeping people healthy or help them to stay healthy and trying to prevent from having to enter into a formal structure. So I think we need to change our frame of reference and really start looking at, because all of the presentation, there's good elements in it, and we know that there's also good programs in the community. And so how do we bridge? I think I go with Shirlee, is how do we start to bridge, and what are the sets of principles? And certainly CNA and CMA have worked on principle of how do we start to connect the dot by agreeing on it and arriving at a consensus around principle that will help us actually work towards keeping people healthy and having to enter into a formal system. So I think we need to change our way of reference, and I think you've touched on some of the elements, and I'd like to see if you could start, looking at it, what are some of those elements that we need to start to bring to try to really transform?
That I don't think my mic is on. There you go. It's not data that I presented, but in this telehealth practice that I have, so this is so I'm in Alberta, the individuals receiving care in Newfoundland, and it's actually an interprofessional team, basically. It's a primary health care team, basically, if you look at it, that's delivering that model. It's primary health care nurse practitioner, diabetes nurse, a dietitian, and an LPN. They're doing it, and I think what's really been neat about this is a group of patients that are all on insulin pumps, and I would challenge you, I suggest that if you look across Canada, in lots of other models where those kinds of patients are receiving care, they're actually in tertiary kinds of environments. And what we've demonstrated is that with a nurse-led model, and that I'm not present, but I'm 24/7 accessible through e-technology. Patients can get in touch with me anytime they want, or with any member of the team. We've delivered a care model that actually, when you ask, we regularly have town hall meetings with our practice. We meet with them twice a year, and we go to them and we say, here's what we see, here's how it's working. We present them some of the data about the practice, how the practice is performing, and how their metrics are. So we actually present patient-level metrics back to the patient cohort and say, what do you think? I'm concerned about the A1C numbers. Gosh, these don't seem so good to me. And they say, that's not so important to us because I care about my quality of life. I care about the fact that I have autonomy and I want to do certain things in my life. So I didn't present that story to you today, but maybe I'm trying to reestablish my credibility as someone who kind of gets the primary care level. But I would say to you that one of the most important things we do is we really need to stand back and ask ourselves the question, what's our end game and what are we trying to accomplish? And we will only maintain relevance in that agenda if we actually stand back and ask ourselves, what's the requirement? What is the care requirement? And that's what we've done. And that patient and family voice have been hugely important to us in terms of understanding what the care agenda is. And when patients and families talk about access, they're not talking wait times. They're talking, I have an issue today, I need help today.
I think we're actually out of time. So, Shirlee, did you have something quick to want?
I do think the broader issue is actually it's not about hospitals, home, and community divide. I actually think what it's about is people-centered care as the starting point. Health Canada helped fund an initiative that St. Eliz was privileged to be part of, where we've produced an incredible literature review on people-centered care. And it goes into standards and starting points and initiatives and great evidence of how we should be anchoring what we're doing. And I think unless we get out of even population-based planning, and I think that's a piece of it, but really begin to anchor what we mean by person-centered and person-focused approach to what we're doing, we'll free ourselves from the sectors, from the areas that we are currently in, and stay on the prize to what is the opportunity with people to do different. So I don't have the link to that report, but it is on St. Elizabeth's website. And as I say, Health Canada funded that initiative, and it's a great piece of work, really helping us move through evidence from people-centered care.
Thanks very much. Thanks for your attention.